Definitions of PCI success. PCI success may be defined by angiographic, procedural, and clinical criteria. Angiographic success in a stented artery is a minimum stenosis diameter reduction to less than 20%. Procedural success. A successful PCI should achieve angiographic success without in-hospital major clinical complications like death, MI, bypass surgery during hospitalization. MI is often defined as the development of Q waves in addition to elevation of troponins 3 times the upper limit of laboratory's normal value. Cardiac troponins T and I as measurement of myocardial necrosis are more sensitive and specific than CKMB. Enzyme elevation in the absence of new Q waves is counted as MI periprocedural. There is no consensus on what level of troponin alone is clinically important enough to change major management following the interventional procedures. Clinical success. A clinically successful PCI is an anatomical and procedural success with relief of signs and or symptoms of myocardial ischemia after recovery from the procedure. The long-term clinical success requires that the patient have persistent relief of signs and symptoms of myocardial ischemia for more than 6 months. Restenosis is the principal cause of lack of long-term clinical success when short-term clinical success has been achieved.
Mechanism of angioplasty and stenting. Number 1. Disruption of plaque and arterial wall. The inflated balloon exerts pressure against the plaque and arterial wall, causing fracturing and splitting. Concentric, round, or circumferential lesions fracture and split at the thinnest and the weakest points. Eccentric lesions split at the junction of the plaque and the normal arterial wall. Dissection or separation of the plaque from the vessel wall releases the restraining effect caused by the lesion and results in a larger lumen. This is the major mechanism of balloon angioplasty. Loss of elastic coil. Balloon dilatation causes stretching and thinning of the medial wall. Stretching causes the vessel wall to temporarily lose its elastic recoil properties. The degree of elastic recoil is affected by the balloon to artery size ratio. Almost all vessels have some elastic recoil. The major initial benefit of stenting is the elimination of elastic recoil, maintaining a large lumen over time. Redistribution and compression of plaque components. During angioplasty, balloon pressure causes denudation of the vessel wall lining, endothelial cells, and the extrusion or pushing out of plaque components. There may be some molding and extrusion longitudinally of the softer lipid material, but this effect accounts for a very small part of the overall effect. Contraindications to PCI include bleeding, diathesis, low platelet count, peptic ulcer disease, coagulopathy, patient non-compliance with procedure and post-PCI instructions, and inability to take dual antiplatelet therapies. Multiple PCI restenosis are contraindications to PCI. Some patients with contraindications may have PCI as their only alternative for revascularization strategy. Complications of PCI are that death can occur in 0.1% cases, MI in 1 to 3% cases, and emergency bypass surgery is required in 0.5 to 2% cases. All complications that can occur during diagnostic cardiac cath can also occur during PCI, like excess site bleeding, especially with larger sheaths and prolonged anticoagulation, 1 in 250 patients. Contrast medium reactions can occur, cerebrovascular accident, MI, and vascular injury. For example, pseudoaneurysm of femoral artery can occur as a complication of PCI. Restenosis at the site of PCI occur in approximately 10% patients and may lead to recurrence of anginal symptoms. Typically, most frequently occurs within the initial 12 months after PCI. This biologic effect is not considered a complication but rather a clinical part of angioplasty. Relative contraindication to diagnostic cardiac cath include acute GI bleeding, severe hypokalemia, uncorrected digoxin toxicity, INR more than 1.8, or severe coagulopathy, previous anaphylaxis reaction to contrast, acute stroke, acute renal failure, or severe chronic non-dialysis dependent kidney disease, unexplained fever or untreated active infection, severe anemia, recent CVA less than 1 month, uncooperative patient, and pregnancy. Invasive angiography is appropriate in high pretest probability of coronary artery disease with uninterpretable ECG or unable to exercise. Sustained VT and ventricular fibrillation are also indications for invasive angiography. Risk factors that support early invasive evaluation include significant troponin increase, diagnostic ST/RT wave changes, Grace score more than 140, diabetes mellitus, ejection fraction less than 40%, early post-infarction angina, recent percutaneous intervention, prior bypass surgery, intermediate to high Grace risk score. PCI equipment. The most commonly used PCI equipment consists of four basic elements: guiding catheter, balloon catheter, coronary guide wire, and a stent. The approximate cost of coronary angioplasty equipment can be from 300 US dollars for balloon dilatation catheter to $2,300 for drug eluting stents. There are three major operational challenges with PCI. First is placing the guide catheter in a stable position. Second is negotiating tortuous vessel segments with the guide wire. And third is delivering the stent through tortuous segments. To complete the PCI, the operator must control the three principal movable components, that is guide catheter, balloon catheter, and guide wire simultaneously. Guiding catheter, a special large lumen catheter used to deliver the coronary balloon catheter and other interventional devices to the vessel that contain the lesion to be dilated. The features of guide catheter are given in this figure, which shows first as a stiffer body. 2 label is given to variable softer primary curve. 3 is wire braiding of the guide catheter. 4 is the atraumatic tip of the guiding catheter. 5th is the large lumen with optional radio opaque marker, and 6th is lubrious coating of the guiding catheter. Functions of guiding catheter is that it serves three major functions during angioplasty. First is balloon stent catheter delivery and guidance. Backup support for balloon stent advancement is the second function, and third function is monitoring pressure and giving contrast injections. Balloon catheter delivery and guidance. To deliver the balloon catheter to the coronary artery over the guide wire, the guiding catheter should be seated with the tip parallel to the long axis of the artery at its origin, that is coaxial. Coaxial alignment permits safer transmission of force needed to advance the balloon across a stenosis. This act may require guiding catheter repositioning or occasionally deep seating into the artery. Adequate contrast injection through the guide catheter is critical to position the balloon stent and depends on the size of the catheter lumen with the angioplasty device in place. A guiding catheter must be large enough to permit adequate contrast administration with the PCI catheter in place to pacify the target vessel and visualize the lesion. Large non-balloon PCI devices in small guiding catheters may not allow adequate vessel visualization during angiography. Large non-balloon PCI devices include rotablator, thrombus aspiration catheters, etc. This problem has been overcome with the larger lumen, yet small guide catheters and contrast media power injectors in some cath labs. Operator should select a guide catheter with a lumen diameter large enough to allow enough contrast flow around the PCI device to permit clear angiographic imaging of the lesion. As balloon and PCI catheters have become smaller, the size of the internal diameter of the guiding catheter has become less important for achieving adequate visualization. A large guide catheter lumen, however, is critical to facilitate easy passage of double balloon stent systems for complex or bifurcation lesions. Characteristics. Compared with the diagnostic catheter, the guiding catheters have thinner walls, larger lumens, and smaller shafts. A large catheter lumen is achieved at the expense of catheter wall thickness and thus may result in decreased catheter wall strength, less torque control, or catheter kinking. The guiding catheters are generally stiffer to provide backup support during the PCI catheter advancement into coronary artery and therefore respond differently to manipulation than diagnostic catheters. The guiding catheter tip is not tapered. Pressure wave damping upon engaging the coronary ostium is seen more often than with similar sized diagnostic angiographic catheters. Some guide catheters have relatively shorter and more flexible tips to decrease catheter induced trauma. Guiding catheters with small side holes near the tip permit blood to enter the coronary artery when the ostium is blocked by the guide catheter. Side holes are used when the guide catheter either partially or totally occludes blood flow into the coronary artery. The guide catheter coronary occlusion is noted by change in arterial pressure waveform to one of damping. Catheter side holes reduce ischemia when the guiding catheter is seated in small artery. However, side holes may lead to inadequate artery visualization from loss of contrast media exiting the catheter before entering the artery. Although side holes may provide reliable aortic pressure, coronary flow can still be compromised during the angioplasty procedure. The guide catheter and side holes act as a second stenosis at the coronary ostium. Small shaft diameter guide catheters like 6 French are the most frequently used size of guiding catheter. The use of small diameter guide catheters result in fewer femoral vascular complications and allow earlier ambulation of patients. Small size less than 5 French guide catheters do not allow for the use of some stents. Guide catheter sized 7 French or 8 French are used for complex procedures involving larger PCI devices or two stents for treatment of bifurcation lesions. Use of 6 French or in some patients 7 French guide catheters from the radial artery approach may become the favored access because of the markedly reduced vascular complications associated with radial PCI procedure. So there are three types of balloon dilatation catheter systems, and these include first as over the wire or OTW, second is monorail, and three is fixed wire. Characteristics: the plastic material of balloon determines its compliance, which is defined as the amount of expansion or diameter size for given amount of pressure and strength. Compliance is the main differentiating feature among balloon catheters. Inflation of a compliant balloon above factory determined average mean pressure, also called nominal or a set pressure for a known balloon size, will lead to further expansion of the balloon size approximately 10 to 20% over the predicted diameter. Non-compliant balloons, on the other hand, remain very close to their rated diameter even when inflated several atmospheres above nominal pressure. The advantages and disadvantages of balloon materials remain controversial. A compliant balloon may produce oversizing, particularly on second and third high pressure inflations, resulting in dissections. After most stents are deployed, post deployment high pressure inflations are performed with low compliance or non compliant balloons to implant the stent struts into the vessel wall. Most balloons are also coated with low friction surface polymers to facilitate lesion crossing. The mechanical aspects of balloon inflation apply the following fundamental principles. Overinflation at balloon ends. According to Laplace law, wall stress increases with radius. At a given pressure, a larger balloon undergoes more wall stress than a smaller balloon, promoting balloon rupture. The arterial segment next to the lesion has a larger luminal radius than the lesion. Thus, artery sites adjacent to the lesion may be traumatized. At high pressures, balloons weaken over time. The balloon burst pressure may be decreased during subsequent inflation of the same balloon. When inflation when inflating a balloon above the rated burst pressure, operators should consider limiting the number and duration of inflations. Balloon diameters always increase with increasing pressure. Even non-compliant NC balloons will grow in diameter usually by nearly 10% over nominal with high pressures. Compliant balloons may increase by more than 20%. The balloon diameter pressure relation is usually linear, reflecting the compliance characteristics. Balloons do not return to their original dimensions after deflation. At any given pressure, the balloon diameter during a subsequent inflation will be larger than during the first inflation. When dilating two lesions with a compliant balloon, cardiologists should consider approaching the narrower lesion first. The selection of a balloon catheter is highly subjective and less critical in the current era of stents. The balloon size is selected to achieve a 1:1 size match with the vessel. Balloon to artery ratios of more than 1.2:1 are associated with increased complications. Larger balloons 30 to 40 mm are useful for dilating long and diffuse narrowings. Short 10 to 15 mm balloons are used for stent expansion to avoid stretching the vessel wall outside the stent. The balloon size is determined with the distal arterial reference segment diameter as gauged by the size of the guiding catheter. For example, 7 French 2.31, 8 French 2.64, 9 French 2.97, and 11 French 3.63 mm. Visual estimation of artery diameter is less accurate than quantitative angiographic and IVUS imaging approaches, but it is the method used by most interventionalists. From IVUS studies, most stents selected by visual sizing are 0.5 mm smaller than true vessel dimensions. Important technical considerations for selecting PCI systems include catheter profile, trackability, pushability, and ease of exchange. The size of a deflated catheter has been emphasized in catheter selection. Stent profiles are now very small with profile sizes of 0.035 and 0.033 inches. There appears to be no practical difference among equipment sizes. Stent profile is not the only factor in facilitating a stent to cross a lesion. Trackability is the ability to advance the stent through the vessel to reach the lesion and is a function of friction related to both the guide wire and the delivery catheter. Although stent systems are marketed based on their ability to track and conform to the vessel, trackability is difficult to measure in an objective manner. For a balloon to track, it must be able to transfer force through the shaft of the balloon catheter, a feature referred to as pushability. There may be little difference in the pushability of majority of the available systems. Resistance to balloon catheter forward motion may occur as a result of guide wire balloon friction, balloon guide catheter friction, or balloon artery friction. Ease of device exchange is strong consideration. The monorail catheter system is the quickest and easiest to exchange. The standard OTW balloon requires the placement of a long guide wire or the attachment of an exchange system to the end of the guide wire or a guide wire tripping system. A rapid exchange system reduces X-ray exposure time because fluoroscopy is not required if the wire is fixed during catheter removal. Balloon inflation strategies. Stenosis resolution occurs when the balloon pressure eliminates the balloon indentation caused by the stenosis called the waist. Unstable or thrombotic lesions are generally soft and compared with chronic stable lesions are associated with a lower balloon inflation pressure. Most coronary lesions respond to inflation pressure of less than 10 atmosphere. Calcific or fibrotic lesions may require higher inflation pressure of 12 to 17 atmosphere to eliminate the balloon waste. Because stenting after PTCA is now a routine, issues regarding optimal balloon inflation strategies are relatively unimportant. Balloon inflations are generally brief, less than 60 seconds. The balloon should be inflated long enough to permit elastic tissue to relax or stretch. However, in lesions not receiving a stent, high pressures in compliant balloons may produce an oversized balloon to artery ratio associated with an increased incidence of dissection and complications. Low pressure inflations may reduce complications. Most procedures start with low pressure, but operators often feel compelled to use higher pressures to achieve satisfactory angiographic results. PCI guide wires are small caliber 0.010 to 0.018 inch steerable wires advanced into the coronary artery or its branches beyond the lesion to be dilated. A J tip of varying degree, usually shaped by the operator, allows steering across side branches through tortuous artery curves. Guide wires are made with an inner core wire and an outer spring tip. The shorter the distance between the end of the central core and the spring tip, the stiffer and more maneuverable the wire will be. Differences in core construction affect guide wire handling. When a guide wire is selected, important considerations include diameter, coating, torque control, flexibility, malleability, radio opacity, and trackability. The diameter for the most commonly used coronary guide wire is 0.014 inch, although diameter from 0.010 to 0.018 inch are available. Larger diameter guide wires have better torque and backup support, while small diameter wires are more maneuverable. Custom tip shaping will help steer the guide wire. Characteristics. The selection and placement of a guide wire distal to the stenosis depend upon the clinical situation and the operator's experience and skills. The following terms are applied to angioplasty guide wires. Stiffness of the guide wire determines specific performance. Soft wires are safer and easier to advance through tortuous artery branches. Stiff wires torque better and are often useful for crossing difficult or total chronic occlusions. Extra stiff guide wires provide better support for intracoronary stent placement in highly tortuous arteries. Steerability is defined as the ability to turn and advance the wire through tortuous segments and side branches by rotation of the wire. Steerability is an important feature of guide wire. Flexibility is determined by the distance from the end of central core to the distal spring tip of the wire and is important in avoiding vascular trauma when crossing and recrossing lesions. Malleability is the ability to shape the spring tip and maintain a desired tip shape. Repeated attempts with different wire tips configurations may be required to cross distal stenosis. The manufacturer performs some guide wire shapes. The manufacturer preforms some guide wire tip shapes. Guide wire
Tip shaping is accomplished by bending the wire between the thumb and index finger, or rolling the guide wire tip over a needle, or bending the wire tip at the end of an introducer tool. In general, the length of the distal bend in a large vessel should approximate half the usual diameter of the vessel, about 2 mm. A larger bend may be needed to reach a takeoff when the wire is steered into an abruptly angled branch. A double 45-degree bend is often helpful. Guide wire tip curves that can facilitate difficult anatomical problems during PTCA. Number of angulations. Single. Configuration of the tip. Angle is mild or moderate. RD is smaller than the diameter of LMCA. Tip is similar to commercial J curves. Location of the lesion for proximal RCA circumflex or LAD lesions. Characteristics of the coronary anatomy. Vessels are straight. Takeoff of the branches is shallow. Difference in diameter of LMCA and a narrowed branch is not marked. Rationale is lesions are easily reached with only minimal manipulations. Double angulations, proximal and distal angles are mild or moderate. Total RD approximates the diameter of the LMCA. Distal RD is similar to the diameter of the narrowed branch. Location of the lesion when proximal are mid RCA, LAD, and circumflex. Characteristic of the coronary anatomy vessels are mildly tortuous, branches take off with mild to moderate angles. Difference between the diameter of the LMCA and the diameter of the narrowed branch is not marked. Proximal angle adds RD to improve entry into the branches of the large proximal vessels. Distal angulation allows easier manipulation in the smaller narrow distal branches. Number of angulations double for this other catheter, which has configuration of the tip as shallow distal angle with proximal angle steeper. Total RD is unchanged from the above guide wire tip, and this is used for proximal mid or distal RCA circumflex and LAD lesions. Characteristic of the coronary anatomy for which it is used is tight stenosis trifurcation, are two opposing branches originating from the same segment, for example septal and diagonal branches of the LAD. The lesions more easily. The shallow distal angle with small RD has tendency to remain centrally located, avoid side branches and traverse. Other guide wire with double angulations, which has a steep distal angle with short arm and small reaching distance. Proximal RD is unchanged for this guide wire tip curve. Location of the lesion when distally, primarily in obtuse marginal or diagonal arteries. And characteristics of coronary anatomy is that vessels have sharp bends and kinks. Narrowed branches have sharp angles. The difference in diameter of the LMCA and the narrowed branch is very marked. For example, the diagonal branch taking off sharply and subsequently curving, resembling a smaller letter H. Rationale is that steep distal angle is required to enter the side branches at the proper angle and improves advancement of the wire around the steep curve. For this double angulations guide wire tip curve
Number of angulation still double with configuration of the tip is that there is a long proximal arm to be required, and it is used if LMCA has large diameter and LAD or circumflex has a sharper angle of origin, more commonly with circumflex. Rationale is that longer proximal arm aids RD, thus improving entry into the large proximal vessels, LAD or circumflex. Another guide wire tip curve, that is double curve, very long proximal arm. Distal arm is shallow, used for severe stenosis of proximal circumflex, rarely LAD. The vessel has a takeoff of 90 degree or more from the LCA with subsequent posterior curve. The lesion is severe, located immediately distal to the band. Rationale for the use is that the very long proximal arm permits the distal angle to function independently, facilitating vertical entry into the lesion. Number of angulations are double, both arms are long. Total RD is larger but usually smaller than the diameter of the large vessels. It is used in the coronary anatomy of large vessels, for example, severely arteriosclerotic abdominal aorta or iliac arteries. Large arteries, large RD is required to enter eccentrically located lumen, often from the aneurysmal areas, is the rationale for the use of this guide wire tip curves. Triple or multiple curves, angles are moderate, distal arm is shorter, total RD is large, used for lesions in mid or distal major vessels. The difference in diameter of LMCA and narrowed branch is very marked, and this is applicable to be used or LAD or circumflex originating steeply. Rationale for the use of this guide wire tip curve is that transition from the long to short arm and advancement of the wire around a sharp angle of the proximal vessel are smoothest. RD is reaching distance here. Guide wire tip curves that can facilitate difficult anatomical problems during PTCA. Number of angulations. Single. Configuration of the tip. Angle is mild or moderate. RD is smaller than the diameter of LMCA. Tip is similar to commercial J curves. Location of the lesion for proximal RCA circumflex or LAD lesions. Characteristics of the coronary anatomy: vessels are straight, takeoff of the branches is shallow, difference in diameter of LMCA and a narrowed branch is not marked. Rationale is lesions are easily reached with only minimal manipulations. Double angulations, proximal and distal angles are mild or moderate. Total RD approximates the diameter of the LMCA. Distal RD is similar to the diameter of the narrowed branch. Location of the lesion when proximal are mid, RCA, LAD, and circumflex. Characteristic of the coronary anatomy: vessels are mildly tortuous, branches take off with mild to moderate angles. Difference between the diameter of the LMCA and the diameter of the narrowed branch is not marked. Proximal angle adds RD to improve entry into the branches of the large proximal vessels. Distal angulation allows easier manipulation in the smaller narrow distal branches. Number of angulations double for this other catheter, which has configuration of the tip as shallow distal angle with proximal angle steeper. Total RD is unchanged from the above guide wire tip, and this is used for proximal mid or distal RCA circumflex and LAD lesions. Characteristic of the coronary anatomy for which it is used is tight stenosis, trifurcation, are two opposing branches originating from the same segment, for example, septal and diagonal branches of the LAD. The lesions more easily. The shallow distal angle with small RD has tendency to remain centrally located, avoid side branches and traverse. Other guide wire with double angulations, which has a steep distal angle with short arm and small reaching distance. Proximal RD is unchanged for this guide wire tip curve. Location of the region when distally, primarily in obtuse marginal or diagonal arteries, and characteristics of coronary anatomy is that vessels have sharp bends and kinks, narrowed branches have sharp angles. The difference in diameter of the LMCA and the narrowed branch is very marked. For example, diagonal branch taking off sharply and subsequently curving, resembling a smaller letter H. Rationale is that steep distal angle is required to enter the side branches at the proper angle and improves advancement of the wire around the steep curve. For this double angulations guide wire tip curve, number of angulations still double with configuration of the tip is that there is a long proximal arm to be required, and it is used if LMCA has large diameter and LAD or circumflex has a sharper angle of origin, more commonly with circumflex. Rationale is that longer proximal arm aids RD, thus improving entry into the large proximal vessels, LAD or circumflex. Another guide wire tip curve, that is double curve, very long proximal arm. Distal arm is shallow, used for severe stenosis of proximal circumflex, rarely LAD. The vessel has a takeoff of 90 degree or more from the LCA with subsequent posterior curve. The lesion is severe, located immediately distal to the band. Rationale for the use is that the very long proximal arm permits the distal angle to function independently, facilitating vertical entry into the lesion. Number of angulations are double, both arms are long. Total RD is larger but usually smaller than the diameter of the large vessels. It is used in the coronary anatomy of large vessels, for example, severely arteriosclerotic abdominal aorta or iliac arteries. Large arteries, large RD is required to enter eccentrically located lumen, often from the aneurysmal areas, is the rationale for the use of this guide wire tip curves. Triple or multiple curves, angles are moderate, distal arm is shorter, total RD is large, used for lesions in mid or distal major vessels. The difference in diameter of LMCA and narrowed branch is very marked, and this is applicable to be used or LAD or circumflex originating steeply. Rationale for the use of this guide wire tip curve is that transition from the long to short arm and advancement of the wire around a sharp angle of the proximal vessel are smoothest. RD is reaching distance here. Radio opacity, marker bands, and special coatings. Visualization of the guide wire is provided by a radio opaque coating, usually applied only to the distal part of the wire. The limited radio opaque segment permits lesion visualization without obscuring useful angiographic details such as small dissections. Calibrated radio opaque marker bands are used to gauge lesion length. Angioplasty balloons usually have two markers, one at each end of the balloon. Small balloons, for example 1.5 mm diameter, have one central marker. These markers may be confused for markers on some guide wires. Various wire coatings increase ease of wire movement within the balloon, catheter, and artery. Some coated plastic tipped wires, especially with hydrophilic tips have higher likelihood to perforate. Exchange and extension guide wires. An exchange guide wire is similar to those mentioned previously, except that its length is 280 to 300 centimeter. This long wire replaces the initial 140 centimeter wire when an exchange of the balloon catheter is necessary, for example, upsizing balloon or insertion of stent. Alternatively, a 120 to 145 centimeter extension wire can be connected to a companion 145 centimeter guide wire, thus creating a long exchange guide wire to allow balloon catheter exchanges. Accessory equipment: adjustable hemostasis and rotating Y connector valve. The Y connector is attached to the guide catheter to permit introduction of a PCI catheter into the guide while allowing contrast injection through the guide catheter. The end of the Y connector has a rotating hub and a valve. The valve minimizes back bleeding from the guide catheter while the PCI catheter is inserted or removed. The Y connector also permits pressure monitoring through the guiding catheter regardless of the PCI catheter position. Balloon inflation devices. A disposable syringe device is used to inflate the balloon on the PCI catheter. A pressure gauge display indicates the precise inflation pressure in atmosphere, ATM or torr, or pounds per square inch PSI. Typically, the balloon is inflated with sufficient pressure 4 to 12 atm to fully expand the stenosis indentation, dumbbell, or waist of the partially inflated balloon. Occasionally, some calcified or highly fibrotic lesions require very high inflation pressures more than 14 atmosphere to expand and eliminate the dumbbell appearance of the balloon. Overinflation of the balloon increases the risk of artery dissection. Guide wire, torque, tool device, and guide wire introducer. A small cylindrical pin-wise clamp slides over the end of a guide wire and permits the operator to perform fine steering manipulation of the guide wire. A guide wire introducer is a thin, needle-like tube with a tapered conical opening on one end which helps the operator insert the guide wire through a connector valve or into a balloon catheter. Stents reduce abrupt vessel closure from dissections and coronary restenosis. The implantation of coronary stents has superseded traditional balloon angioplasty and is the most widely practiced procedure of PCI. The multitude of stent design has arisen because of patent design issues, improved scaffolding mechanism, and unique coatings. Most of the advances in stent design have been to increase deliverability. Stent delivery depends on both stent flexibility and profile, which must be designed without sacrificing radial strength and scaffolding length. The characteristics of an ideal stent are biocompatibility, conformity to tortuosity, flexibility, high radial strength, low metallic surface area, low profile, radio opaque, secure delivery system, side branch access, thrombo-resistant, and trackability. S slowly releases a drug to block cell proliferation and restenosis. Cypher, Texas, Science V, and Endeavor. Bare metal stent is thin metal wire or mesh stent without a coating, typically first generation technology. BX Velocity Express 2 and Millennium Matrix. Bare metal stent, a vascular thin metal wire or mesh without a coating, typically is a next generation technology of driver, multi-link vision, coronium, and absorbable stents are completely biodegradable, bioabsorbable, typically polymer or magnesium, sometimes coated with anti-restenotic agent, AMS, absorb trial, REVA, and resorb trial are absorbable stents. Bioactive stent is a stent that reacts with the body's natural processes to achieve an anti-restenotic effect. Genos and Titan 2 bars. Radioactive stent is stent with radiation emitting coating. Name is undisclosed for radioactive stent. Drug-eluting balloons, angioplasty balloon that after deflation leaves behind an anti-restenotic drug. These include Dior, DIOR, and Elutax, ELUTAX. Relative contraindications. Relative contraindications to stenting can be related to patient and anatomical factors. In patient factors, GI bleeding that prevents 4 to 5 hours of anticoagulation during or following the stent procedure, inability to take dual antiplatelet, conditions that prone patient to hemorrhage, intracranial hemorrhage, recent surgery or bleeding diathesis. Anatomical factors: small vessels less than 2.5 mm, vessels with poor distal runoff or severe diffuse disease, vessels supplying poorly functional or non-functional myocardium, and heavily calcified vessels. Complex stenting. Stenting for patients with complex anatomy should be carefully considered. Any of the following characteristics are considered at high risk for complications: long lesions requiring more than one stent per lesion, small coronary artery reference vessel diameter less than 2.5 mm, significant thrombus at the lesion site, lesion in saphenous venous graft, the left main coronary ostial locations are bifurcation lesions, restenotic lesions, diffuse disease or poor outflow distal to the identified lesion, very tortuous vessels in the region of the obstruction or proximal to the lesion, unprotected left main stenosis, complex coronary artery disease with significant impairment of LV function. Over the past decade, the indications for stenting have expanded, demonstrating a favorable outcome in nearly every anatomical subset studied. These subsets include native coronaries that are 3 mm or less in diameter, stenotic vein grafts, restenotic lesions after non-stent interventions, chronic total occlusions, acute MI, bifurcation lesions, ostial lesions, unprotected left main stenting, multivessel stenting. Potentially favorable but as yet unproven situations for stenting include small vessels, long lesions, and diffuse disease. Stent types and their characteristics. Drug-eluting stent is a stent that slowly releases a drug to block cell proliferation and or restenosis. Cypher, Texas, Science V, and Endeavor are drug-eluting stents. BMS stainless steel is a vascular thin metal wire or mesh stent without a coating, typically first generation technology. BX velocity expressed to millennium matrix are the BMS stainless steel. BMS metal stent cobalt chromium is a vascular thin metal wire or mesh without a coating, typically next generation technology with driver, multi-link vision, and coronium stents as BMS cobalt chromium stents. Absorbable stents are completely biodegradable, bioabsorbable stents, typically polymer or magnesium, sometimes coated with anti-restenotic agent. AMS, absorb, REVA, resorb are absorbable stents. Bioactive stent is a stent that reacts with the body's natural processes to achieve an anti-restenotic effect. Genius and Titan 2 bars are bioactive stents. Radioactive stent is a stent with radiation emitting coating. The name has not been disclosed, made by Mobita Incorporation's radioactive stents are made by them. Drug-eluting balloon is an angioplasty balloon that after deflation leaves behind an anti-restenotic drug. Sequent, Please, Dior, and Elutex are drug-eluting balloons. Contraindications to stenting can be determined based on patient and anatomical factors. Patient factors: GI bleeding that prevents 4 to 5 hours of anticoagulation during or following the stent procedure. Inability to take dual antiplatelet therapy, aspirin, and thienopyridines like clopidogrel. Conditions prone to hemorrhage, intracranial hemorrhage, recent surgery, or bleeding diathesis. Anatomical factors: small vessels less than 2.5 mm, vessels with poor distal runoff or severe diffuse disease, vessels supplying poorly functional or non functional myocardium, heavily calcified vessels.